All right, today we have Isaac Marslick, and as you all know, he's a pain medicine or management specialist with Health Partners. He was great enough to come back and give another talk. He's given quite a few. He's one of the leaders, I think, and people that have given talks.
Jeez. Okay.
Yeah, you've given a few over the years.
That's true.
Next slide. We'll get to his talk in just a moment. Just remember, we have a few announcements we'll go through quickly. I think everybody's pretty sick of me going through these, but we kind of got to do it. We have a gazillion talks coming up that are really good. I don't even have to put mine in there yet. I'm saving this one till we run out of a speaker. But as you can see, next week, we're going to talk a little bit about telehealth, which, as you know, there's been a few little changes potentially coming with that, with prescribing potentially substances that are controlled. So that's coming down the pipe. So we'll get everybody up to date on that. And so lots of fun things coming. Next slide. Yeah, so there's CME. Remember, just make sure you fill out the thing at the end so that you get your CME. We will just make sure that you turn on your video if you can too, so people can see you, because that makes this way more fun. And if there's somebody else in your room, just make sure you tell us so they get the CME. Just send a text or a chat to Katie and she'll get them on the list. Remember, give us a call if you have any questions. Their phone numbers have been there forever. Most everybody's got them. Got some interesting calls lately on Kratom, which has been amazing. Next slide. And we have the resources thing. Our manual is going to be up there very soon. I keep saying that, but I'm just going to keep saying that. I won't explain it at all. I'm just going to tell you it'll be up there sometime soon. Next slide. And remember, this week actually was our podcast of compassion fatigue, which is a shortened version of a talk that I'll be giving sometime down the road. And actually, another talk I'm working on is teneptine. I don't know if anybody's seen teneptine lately, but I just had the most amazing teneptine case. Next slide. So we're going to let him share. If you want to turn that off, Katie, he's going to share his slides. And if you want to introduce yourself a little more, Isaac, that'd be great.
Sure. Right. So let me see if I got it here. And boom. Okay. Everybody can hear me and can see my first slide.
All systems go.
Okay, great. So yeah, thanks for the introduction. My name's Isaac Marslick, as was kind of talked about. I'm a pain management physician at Health Partners, and about half my time's in the hospital doing inpatient pain. Then the other half is outpatient with some procedures, mostly chronic pain management and a ton of back pain management, and then some administrative stuff kind of thrown in. So like most of my talks, we have to go back in time to start with. That's how I usually start my talks. So I'm going to go back to 2014. I had just started tango dancing, and I was down in Rochester. And down there, Fabian and Lola were putting on a course. And you can kind of see, this was actually what we were working on. You can kind of see him kind of sticking his back leg, and he's kind of catching her kind of trailing leg there. And this move is called a cicada or a displacement. And it looks really cool when you do it. And you can kind of see how he's sort of twisted around himself to make that happen. And so we did probably about 3 hours of variations on these cicadas down in Rochester. And I was feeling really good. I was trying really hard and doing it. And I got done and I felt great. And then I drove back, and that evening had a get together with some friends. And I remember sitting on this wooden bench outside this person's house, and my back locked up. And maybe for those who treat back pain, you've kind of heard this, like people say, my back locked up, or it gave out, or it froze up, or something like that. And I never had this happen to me, so I just assumed it was like muscle tension or whatever. But I was there. I was like, I don't think I can move. So I felt like if I moved in any way, I was just going to get terrible pain. So I just kind of sat there on the bench. And then one of my friends who was in my residency program, we had both just graduated, but he came up and says, "You don't look so good." And I said, "I don't feel so good." And he says, "Well, what are you going to do?" And I said, "I think I just got to go." So somehow I hobbled into the car and got back to my apartment, and then just ended up lying on the floor in my bedroom. And that was sort of where I spent most of the next like 3 or 4 days. And we'll talk about kind of how things ended up for me with that. But we'll just put it out there that lots of people get back pain, including people who give talks on back pain. So
one quick question, Isaac, when you do this little move poorly, do you just fall?
Hopefully not. But so you can see Lola's there, and she's the one kind of doing most of the work because she's making it super easy for him to make the move. And then she's providing a lot of stability while he's trying to do this. I mean, they're both, professional dancers, so they don't have any problem. But when you're, just starting out, you don't typically fall. It just mostly just doesn't work. And then you get terrible back pain afterwards too. So anyway, I'll go on to say that that's not typical for most of the time with the tango. And, anybody who has any interests about tango dancing or playing tango music should totally reach out to me. It's something that I'm super into. So objectives, I think this is always the hardest part of my talk. So I got some help with these. You can kind of see them there. We're going to talk about mostly opioids as related to back pain. We're going to talk about some things that you can talk to your patients about to make interactions maybe go a little bit easier, and then some causes for back pain as well. No financial disclosures. I was recently at a hypnosis conference and they presented this, the older I get, the less I care about what other people think of me. And I thought, oh, that's super true. And I hope that's true for a lot of you as well as you continue on your journey. I kind of want to set the stage for kind of who's giving you this talk and where it's coming from. And that might be different than someone else who might be giving this talk, but we can divide pain up in a lot of different ways. And two of the big ones are, is it acute? Did it just happen? Or is it chronic? Did it happen a long time ago and it's been persisting for a long time? Is it a simple thing like you sprain your ankle and then a few days later you feel better? Or is it complex, polytrauma with substance use and traumatic amputation or something like that? So my practice historically has been kind of down in the chronic complex corner, though I will say with COVID and the difficulties with sort of overcrowding with the ERs and stuff, we have been seeing a little bit more acute back pain in our chronic pain clinic as they're trying to get people out of the ER and into places that can kind of manage it. So I've actually had some more experience now, kind of a little bit more on the acute side. So just to kind of, again, just give you a sense of who's given the talk. And same thing for opioid prescribing. Historically, I've been very, very conservative with opioids. If you take a community, my community being the Twin Cities metro, some people are going to prescribe, standard deviation 1 above, and some are going to prescribe below. And then there's kind of the bell curve in the middle. And I've historically been pretty far over on the conservative side. I will say, as I've gotten more comfortable with buprenorphine, I've been using that a lot more, not typically new starts, but more transitions for people already on opioids. And so it's a little bit a different thing. And that may be for back pain or really anything. I do a lot of transitioning to bup. So the arrow's probably moved a little bit, but in that sort of specific caveat way. And so, someone else giving this talk that was more towards the middle or more towards the higher end may have a different approach to how they would use opioids for back pain. And this is another important thing, is back pain is not a diagnosis. It's really a symptom, right? And I thought we could just maybe take maybe 30 seconds to a minute if people just want to throw out in the chat, what might be a cause of back pain? It's just a wide open question. You can put basically anything in there because there's a lot of causes, but just throw out some diagnoses that might cause back pain. Or if you prefer just to yell it out, we could have people yell it out too, but go ahead and throw some things in there. I can't see the chat, so I'll need some help with that.
So far, we're getting bulging disc, stenosis, shoveling, or too much damn snow.
Too much damn snow. I like that. Okay.
Instability and poor posture, overuse.
Sure.
Fall, depression, poor muscle awareness.
Yeah, depression, muscle awareness. I like this.
Compression fracture.
Yes, compression fracture. Yes, good ones. Good. Okay, yeah, great. So I just took this right off of the Mayo Clinic website, and you can kind of see a bunch of stuff listed there. And great. I mean, everybody put in great things, but you can imagine that if you're treating back pain from a kidney stone, that's going to be a lot different than a spinal cord tumor or a herniated disc or something like that. So this is a really heterogeneous sort of topic, and we're not going to go through all the variations or things like that. It's mostly focused on the musculoskeletal kind of low back pain that people might present with and some of the variations with that. We could give a whole talk on, pregnancy and back pain or spinal cord tumors or something like that. So again, it's just trying to get at that. And that again, gets at some of the difficulty with the evidence, right? Are opioids good for back pain? Well, what's the cause of the back pain and why? And so again, just important to understand that as we're going forward. So I think one of the things to know is that most of the time for the type of things we're talking about, the back pain tends to get better for most people. So this was a pretty well-known study from 1970 where they looked at herniated discs. And it turns out that if you have surgery or you just don't do anything, in about 6 months, things are better for the vast majority of people. And this has been repeated in various ways, and it's about the same. And so one of the things I think is really important for people to understand is that having back pain most of the time gets better from herniated discs and from a number of other things. We'll talk about that here. So here's a couple of pictures. I know not everybody probably looks at imaging of the back, and so we'll go through these a little bit, but there is a big red arrow there to help you know what might be going on. What's going on in this picture over here? I'm waiting for the chat number to go up.
Somebody want to throw in a hazard a guess?
Hazard a guess?
There you go.
Someone get the compression fracture? Perfect. Yeah. So this is looking at an X-ray. These squares are the bones of the spine, and we like them to be nice and square. And this one's kind of crunched down on itself. So this would be a vertebral compression fracture. So then the next question is does this person have pain? That would be sort of the next question. And the answer is we don't know. More than 2/3 of people with vertebral compression fractures, those are asymptomatic. And so you just get an X-ray because someone's having some other problem and you find this on there. Someone may have an acute episode of back pain, and right over L2, they're having a bunch of pain, and you get the imaging and they got a new compression fracture. That compression fracture is causing that pain. But just having it on the imaging doesn't necessarily mean it's the cause of the pain. And that's a really important thing to understand as you're going through and trying to help people with their back pain. It can be, but it doesn't necessarily have to be. And lots of times, like I was saying here, it's not. They're asymptomatic findings. So this is an MRI. And again, this is exactly how I talk to patients about it. These cubes are the spine bones, and in between the cubes are the discs. Okay. This is not a great picture, but the spinal cord is here, this gray here, and that ends maybe about there. And then off the spinal cord comes a bunch of nerves that eventually leave your spine and go down your legs and make stuff move. And this lighter stuff is fat and fluid on either side of the spinal cord. And we like to see a lot of fat and fluid for the spinal cord and nerves to be in. This is a cross-section piece. And so here the person's lying on their back and the legs are coming out of the screen at you. And we're taking slices. And so these are the back muscles here. Here's the belly up here. Here's that bone again. It's the cube. Looks a little more rounded in cross section, but that's the bone. The white stuff in the middle is fat and fluid, and these little gray dots are the nerves. And we like to see a lot of fat and fluid and a lot of little gray dots with lots of space. And as we come down here, we can kind of see how we have a little bit of an hourglass shape. There's a little bit of some kind of narrowing here. And now when we look at this cross section, where did all of our white and our fat and fluid go and our little nerves? And that's spinal stenosis. So it's like a narrowing of the hole where the nerves go down. And so then the question again is, well, man, there's a lot of narrowing there. Does this person have pain? And it turns out that most of the time they don't. So spinal stenosis is a very kind of typical thing that happens with aging. And, these are just a couple of studies. Now, this person comes in and they say, I got really bad back pain. And when I walk a little ways, I get horrible numbness and tingling radiating down the back of my legs. I've been having a little bit more issues with my bladder. Okay, now I'm really wondering, like, hey, this is probably causing a lot of problems and needs to be dealt with. But just having these symptoms or findings on the imaging doesn't mean that people have symptoms related to it. And I found these on the internet, but this is exactly what I had a recent patient come in with. He had both an L2 compression fracture and he had spinal stenosis that was rated as severe. And his pain was directly in his butt on the right side. And he got sent because he needed to be treated for his compression fracture and spinal stenosis. And I said, you're not having any symptoms related to that stuff. So we actually did a injection for his sacroiliac joint and piriformis, and it took his pain away completely. So you just have to know a little bit about sort of what's going on, and just having findings on the imaging, again, doesn't mean there's a problem. It can, and that's really our job to sort that out for people. Okay. All right. So a little data review. This is from a pretty popular, or I don't know, popular, maybe polarizing article would be a better way to describe it, out of the BMJ in 2015. As we were kind of getting into the opioid epidemic, people are starting to look at, well, do opioids help things? And this was specifically looking at low back pain. And it turns out that if you give opioids for someone after a work injury for their back pain, they tend to have worse outcomes after that. And that's for controlling for a lot of stuff. So it's not just someone had a worse injury and that's why they got opioids, but actually controlling for a number of different things. The authors felt strongly that there's something about being on opioids or the opioids effect on the brain and function of people that actually leads to worsening outcomes for them. And this is similar for acute to chronic low back pain. So if you had opioids after an acute episode of back pain, you ended up having worsening functioning at 6 months, again, controlling for a lot of different things that you might say, gosh, well, it probably got affected by something else. And again, they felt that the opioids, and they postulated a few different things, in particular, the increase in apathy people have and the then difficulty of getting moving led to worsening functioning for people. And then for chronic pain, actually, surprisingly, not a lot of trials considering how many people ended up on opioids for chronic low back pain in the 90s and early 2000s. So a lot of studies with really high dropout rates for side effects and lack of efficacy. So then what a number of studies did is they said, well, let's just not pay attention to those group of people that dropped out or it didn't work for. Let's see who it worked for. How did they do? And about a mean improvement of about 30% in their pain. And that's pretty typical for most non-cancer pain conditions. And so a lot of people, side effects and issues with opioids, and then even the people that sort of tolerated them and thought it helped, maybe about 30% improvement. And that has to get balanced with the risks of the medications, which, we've had a jillion talks about that here on ECHO. One of the things that is, I think one of the pitfalls is like, let's use opioids until surgery. So a patient comes in, they're having bad back pain, and we think it's something surgical, and they say, I just want to use opioids till surgery. And this is really common with like the knee replacement crowd or the hip replacement crowd as well. I got a surgery that's going to take care of it. Let me just use opioids till I get that surgery, which seems maybe reasonable on the outset, but it is a bit of a sticky wicket. So one, I don't know if anybody's tried to get a neurosurgery appointment. Hopefully not, because I don't want you to have to go to the neurosurgeon. But at least at our clinic, it's a really long time to get in with some of these some of the surgeons, and oftentimes it gets canceled. We're a level 1 trauma. So sometimes, they have an appointment, but the doc had to do trauma overnight and now it's not available. So, this will be sort of region specific, but in general, specialists have been hard to get into. And so as neurosurgeons, so like, yeah, let's do it. And 3 weeks goes by, a month goes by, 3 months goes by before they finally get their appointment. And now we've been using opioids maybe longer than what we intended. Then the surgery gets delayed. We, at least at our place, staffing's been difficult for lots of institutions. And so if it's an elective surgery, it's sometimes not only they get approved for it after they had the wait time, but now the surgery is going to be a long time to get in for that. So that can be an issue. Or they see the surgeon and the surgeon says, hey, you got to quit smoking, or you got to lose so much weight, or, with your uncontrolled diabetes, we're not going to be able to do surgery. And now what's going to happen? You thought we're going to do this till surgery. Now they're not going to get surgery. They've been on opioids for a while. And now we got to navigate that. And that makes it a little bit tricky. It can cloud the post-op management. The guidelines are pretty clear that surgeons need to manage post-op pain. If it was always that easy, I wouldn't have a little blurb in here about it, but it can be a little confusing for the patient. Like, Dr. Marsalik prescribes my opioids for pain management. Shouldn't he be the one kind of managing my pain after surgery? And the surgeons are like, yeah, that sounds like a great idea. And then it can be kind of challenging that way, especially if it's different systems, right? You're in one system, they're getting their surgery in another system, and being able to communicate can be challenging. This can get worked out, and there can be really great communication and good partnership that can happen. But I'll say it at the very least can sometimes be confusing for the patient as to who's going to manage what. And then the outcomes are just worse if people are on opioids prior to surgery. And this is true for a lot of surgeries, not just back pain. It's been a lot of work done in replacement surgery, knee replacement, hip replacement, abdominal surgery. And so and these are just some citations here. The tricky thing is to know how much for how long, and that hasn't been figured out. If I give someone 5 milligrams of oxycodone today and they have surgery tomorrow, I don't think that's going to really affect their outcome. If someone's on 100 milligrams of oxycodone for 5 years and then has a surgery, they're probably set up to have a worse outcome than someone who wasn't on that. But what's the in between? And I think that's really tough to know, and probably patient dependent. So there's a little bit of some judgment there, but just know in general that if people are on opioids going into surgery, for a lot of different surgeries, there's data on that they have worse outcomes. And what we got next? Oh, okay. So as we've talked on here, the focus has kind of shifted a little bit. Who gets opioids, not what gets opioids. And this is sort of the patient's risk factors are really, really kind of shifted to the forefront versus the diagnosis. And I have a little soapbox about how we do cancer pain and are pretty liberal with opioids for cancer pain. I think there should be something that we look into more as how do we really help people with cancer pain and try to keep them safe. But again, here, this is where the risk factors come in for diagnosis, especially in something like back pain, where we have data that outcomes are not great with opioids. So, and this has been talked about a ton here at the ECHO, as far as, risk factors being a really important thing to understand. So diagnosis is one piece of that, but, having, you can think of a lot of scenarios where someone may have a diagnosis that we think, hey, opioids are something we'd consider using for, but the risk factors are so high, we maybe don't feel comfortable with that in using it in our typical way, or maybe just not at all. So important to think about that. I also think that opioid use and pain relief get conflated. So people say, they were denied pain relief because they didn't get opioids or something like that. This is something in the media that comes up a fair amount. And so opioids are just one medication that can help out of lots of different treatments for back pain. And they work for some people in some way. They are not a magic wand or something that instantly takes away people's pain. Oftentimes they lead to side effects for people or cause problems. And so when I have a patient coming in saying, I need pain relief, I'll say, well, what do you mean by that? Or I need pain medications. And I know 20 different medicines I prescribe for pain. And so usually I get a little bit more specific, do you mean you need opioids for your pain management? And then we can start having a conversation about, what does that mean and why or why not I think that's appropriate or not. But we need to start pulling apart this sort of opioids equals pain relief, because it's just it's just not true for one. And it gets confusing then as we try to move forward with helping people with multimodal pain relief. And so another question to really ask yourself as you're thinking about prescribing opioids for back pain or other things is just how much tolerance do you have for your patient's pain? Because in particular for chronic pain, the pain is going to be there. And we really try to shift our focus on how do we decrease the suffering related to that. And probably for those of us who prescribe opioids, you can maybe think of a time or something where you had a patient that was just really in a lot of distress and you prescribed opioids when you maybe thought it wasn't exactly the best thing, or you weren't sure that it was the right thing to do, but the patient's taken up a bunch of telephone time and nursing time, and they're calling all the time and coming in, and it's just a lot of distress for something that, you know, the typical things that you would do should really help that person over time. And so I've developed a fair amount of tolerance in knowing that my patients have pain, and that's okay. That pain is part of the experience for people, and trying to shift more towards, instead of going from 8 to 7, how do we get you doing more stuff with your grandkids, or what's the most important goals for you, and how can we start working towards that? Because the pain is going to be there. And this is a little bit more into the chronic pain stuff. So just an important thing to consider as you're thinking about prescribing opioids. And probably many of you have seen this before, but this is just the pain times resistance equals the suffering. And again, there's just some data I was looking at the conference that they were talking about how there's a ton of things that helps people's pain a little bit for chronic pain. So we can usually get people from an 8 to a 7 or an 8 to a 6 with a variety of different sort of kind of cognitive treatments or behavioral health things or medications or something like that. But it's not frequent that we go from chronic pain of 8 to 0 unless it's like a misdiagnosis or something like that. But what we can work on is sort of the acceptance piece, and again, sort of shifting to how do we help people with their suffering. This is just an infographic from that paper I was talking about that went through a bunch of the opioids for back pain. If you go to the link, this is actually an interactive thing. So if you click on each of these, it pops up some more information. Again, a lot of this stuff, this was back in 2015. So we're kind of getting into it by now. Everybody hopefully has a pretty good understanding about all the risks and what to do as far as patient screening and when to start opioids and stuff like that. So it's just kind of a thing that they were recommending that is now, I think, in a lot of ways has become what we do, hopefully what we do. So when do I personally consider prescribing opioids for back pain? And this is not an exhaustive list, and I'm sure people can come up with other things that they would consider. But so if I have a geriatric patient who's got that spinal stenosis and they got a bunch of nerve kind of and pain going down their legs, and they're a really bad surgical candidate, and we've tried other things, usually I'll try something like a Butrans patch for them to see if we can get them some pain relief and try to keep the side effects down. This is a lot different than the 60-year-old who has, the same diagnosis, but, is a good surgical candidate, but just doesn't want to do surgery. And so I don't think being on opioids for 20, 25, 30 years is a good solution for that type of pain when we have a surgery that could really be successful in treating that. And I don't know that the risks of 25 to 30 years of opioids is less than the risk of doing that surgery. And so again, that's like how I view it. And someone might say, hey, that's really reasonable. We should try to stop, surgery at all costs. And that means maybe trying those meds, can talk about that. But I just don't think that that's a great way for people to spend a majority of their life on those medications. A new painful compression fracture, we talked about that. So a compression fracture is a broken bone. If someone had a broken arm or a broken leg, we typically would use a short course of opioids for helping with that pain. And that's something that I think is really reasonable. Again, there could be a bunch of risk factors. Someone has a traumatic compression fracture because they were using a bunch of fentanyl and crashed their car and don't want to get into treatment. I'm not sure about sending them home with a bunch of opioids. So there's some caveats to that, but in general, something like this, an acute broken bone, something that I would consider opioids for in the right person. Like I mentioned, I'll transition lots of people to BUP if they're interested in doing that. And usually after talking with them about the risks and benefits that can happen, most people are actually pretty interested in transitioning to BUP once they hear about the safety and stuff. It's not for everyone. And this isn't specific to back pain, but I do a lot of that. And I think it's a great tool to have if you're, in the mix with people on chronic opioids. It really can make a big difference for people. Someone has a really, we call a hot ridic, really bad shooting sciatic pain that just happened and they haven't responded to steroids or the epidural. I might do some opioids to try to help them get through that a little bit. Almost always we're talking about a time limit whenever I am considering opioids for acute pain. We'll do this for 5 days and reassess. This isn't a good long-term option, that kind of thing. So that's that. And then if someone has a flare up and they got something really important they want to do. So I have a chronic pain patient who has something really important, like a big trip or, daughter's getting married or something like that. Their pain's flaring up. I might give them some opioids over for, 4 or 5 days so that they can try to get through that event and be part of, again, because the goal is to spend time with family or to do something like that. So we're trying to help with the goals. And if they're not on opioids in these situations, the opioids tend to work really pretty well for 4 or 5 days. And then it's kind of the conversation of like, I know you felt great on them. That's not how it will stay if you stay on these forever. And a lot of people just, especially with how things have changed, just really don't want to be on opioids. And so it's just been a different conversation now compared to 15 years ago. So anyway, so those are some of the things. I'm sure there's a ton more, and I'm sure people are thinking in their heads, well, I would do it for this, or I would do it for that. And there's a lot of appropriate ways that you could consider doing it. But these are some of the ones that come up more frequently for when I'm considering them. So I spent a fair amount of time talking about the opioid piece and sort of this heterogeneous back pain piece. And I said, in general, it's probably not a great idea to use them for most things. And so then what can you do? And here are some things that I think are pretty helpful. Patients really come to us to know in some ways, like how anxious do they need to be about things? Or we might call that, they're looking for reassurance. But if I don't know what's going on, then automatically my brain goes to worst case scenarios. And then I go see Dr. So-and-so and they say, hey, I've seen this 100 times. It's not a big deal. It's going to get better. That can be really helpful for people. So what patients really need to hear are these 4 things at your visit. And this is taken from Adrian Lowe. He does, physical therapist, done a bunch of pain education and has really researched this as well, actually looking into what are the actual words and things you need to say that help patients do better from a pain management standpoint. So the biggest thing is diagnosis. What's wrong with me? You have a herniated disc. It's something that happens all the time. It gets better in 6 months. And we're going to do these things to try to help you feel better. It would be something like that. Or I don't know what's wrong. We're going to get an MRI to sort that out because I want to know what's going on. Or you've had all this testing and I don't know what's wrong, but I really want you to go see, Dr. Bell, and she'll figure that out for you. Okay. Or whatever it is. But patients really need to know what's wrong with them. So a diagnosis. And then how long is it going to take? It's going to take 6 months. You got a herniated disc. It should be better in 6 months or so. You have really bad spinal stenosis. This isn't going to get better on its own. That doesn't mean that you're going to have symptoms and pain all the time. You can try to do some things to help you feel better, but it's just going to be there unless you do surgery. And maybe surgery is or isn't the right thing, but they just need to know sort of the length of time it's going to take. What can they do to help for it? Well, haven't been doing much of anything. You've been laying in bed, and I think that's really causing you to have some more muscle stiffness and deconditioning. We got to get you out and start moving again, or get you into PT, and that's going to be really important for you to do that. Or, I'm going to prescribe some medication, and I want you to just take it regularly to try to help you get through this flare up, and that can be really helpful. And then, of course, what are you going to do? And that's going to be I'm going to prescribe this medicine or order this test or talk to so-and-so to help figure it out. And if you can answer these 4 questions, it will really improve how patients feel when they're coming in with something that's new and scary to them as far as back pain or another problem. And then a little bit more specific to the back pain stuff, I always talk about Goldilocks with either physical therapy or movement. So, if you don't do anything, you're going to get deconditioned and your muscles are going to get sore and you're going to have worse pain. And if you push it too much, things are going to really flare up and you're going to have a lot worse pain. And so you got to do the just right amount of work that stresses your system in a way that you can start making some gains without flaring things up. And as you're figuring that out, you may have some times where you have some more pain, but that doesn't necessarily mean you're causing any injury or damage. You just kind of pushed it a little too far, and you'll kind of figure that out, probably vary day to day, but we got to start doing something to get you moving again. MRI findings are wrinkles on the inside. I'm going to spend a little bit more time on this. This again is just like, we want to try to normalize the findings. I don't know how many people come to me saying, I got 3 disc bulges and are like freaked out that they're going to be paralyzed or in a wheelchair because of this. And maybe a slight exaggeration, but not a whole lot. There's a lot of anxiety about what the radiologist says on the x-rays and MRIs. And with the CARES Act, they get it instantly. It just goes right to their, we have an electronic portal at Health Partners. They get the results, the full radiologist report before I even see it. And so there can be a lot of like looking things, and then they're on the internet and trying to sort it out. And it just turns into a whole thing. And our job is, again, really to try to ease people's worries about what's going on. And so I often say, just like as we get older, we get wrinkles, and that's just part of the deal. These things that the radiologist is saying, that's just wrinkles of your spine. It's just part of getting older. And sometimes they can cause issues like some people have arthritis in their hands. Sometimes you just see it and it's there and it doesn't hurt. Other times it can be really painful. Same thing with some of the findings on the MRI. Just because they're there doesn't mean they hurt. And it's our job to figure out sort of if they are potential causes or not. You're not the only one. I get that a lot. So you've seen this before? Yes, I've seen sciatica before. I promise you I've seen it. Like you're the 20th person this week that we've talked to about this, right? So sometimes there's a little bit like they want to know that you know what you're doing and that you've seen it before. And of course, with back pain, if you are in the business of treating back pain, you've seen tons of back pain in a lot of different ways, shapes, and forms. So I just always encourage the patient, I see this all the time and you can feel better with it. Lots of people deal with this and feel better from it. And it's, again, just trying to ratchet down the anxiety about what's going on. And then in particular, if it is a lot of those findings on the MRI that just are wrinkles there, I always try to tell people what they can and can't do. Everybody is really worried about injuring things worse or making problems worse with their back pain. And we just want to say, hey, just because you're feeling pain doesn't mean you're having damage or injury. Pain is just like the alarm system to let you know, hey, stuff's going on, but doesn't mean that you're actually injuring yourself. And you can do regular activities and not cause damage or injury to yourself. There's no restrictions in doing stuff. It depends a little bit on what's going on. If someone has a super physical job or something like that, and they have a new herniated disc, I'm probably doing some restrictions with that. But in general, especially if the pain's chronic and has been around a long time, and we don't see a smoking gun for something going on, we have this conversation about, hey, you got to start doing regular things. And then lots of times there'll be really high levels of guarding, right? People got to be really careful about how I move. And that's something really important to address. And there's some ways of doing that. But one is just calling it out. You seem really guarded with you move. You're pretty nervous about moving, that it's going to hurt, aren't you? Oh, yeah, I guess I am. I didn't realize that. Yeah, it seems like you got a lot of muscle tension going on with that. How's that working out for you? Oh, yeah, I feel really tight and worried. So you bring it to light. And then if they are really guarded, I'll usually spend some time working through that with them in clinic, and that's working on trying to do some stretches and getting to sort of, lots of times it's just like, how do you start figuring out what's stretch in your body versus what's pain in your body and start to discriminate the two versus When I connect to my body, all I feel is pain and I get really nervous about it. So we start breaking it down and working through that so that when they go to PT, then they can kind of do some more with PT. And so breaking that guarding response is probably a little bit beyond what we're going to be able to convey in this talk here, but it's an important thing to recognize and at least bring up with the patient that that's going on, because it's usually the thing that's keeping them from being able to progress further with regular activity. So the wrinkles on the inside, this was a study again in 2015 that's often quoted, but these are people, and I don't know how they found any 80-year-olds without any back pain, but they did. And they said, this is what's going on with your MRI. You have no back pain, and 96% of people over the age of 80 have disc degeneration. And you can kind of see the numbers for all these things. And the radiologist is going to comment on all these things there. And so when I have someone who's 45 and they say, I got a disc bulge, I say, yeah, that's pretty normal for your age. And that's something that happens really commonly. And just like you start to get wrinkles and gray hair, you get disc bulges in your back. Okay. So and that's always in conjunction, with their exam and what's going on, because they might have a lot of signs that the facet is actually really flared up and causing pain, and we want to address that. But again, as I've touched on a number of times, just having stuff on the imaging doesn't mean it causes pain. And I think it's really important for our patients to know that. So our radiologists, a lot of them will actually just add this, which is basically the information from that last slide, onto their report because the patient is reading it. Now, I would like to say that the patients read this and they're like, oh, okay, good. I don't have to worry about anything. That does not happen. They still get worried about their stuff, but just to know the radiologists are on top of this too. And it's just, they have to report it out. So again, just something important to touch base with them on, with your patients on. And then pain doesn't mean damage. This is a very fancy drawing that I almost always do with my patients, especially if they've had pain over time. But if you take your hand and you start pinching your hand, you have sensation first. You feel the sensation as you pinch. And as you apply more pressure, eventually you get to having some pain. It starts to hurt. And now if I really crank on it, or I got like a pliers or something, I would actually damage my hand or skin there. And so pain is kind of the warning sign. As people get more sensitized to pain and have pain longer over time, that warning system starts going off a lot sooner. So I start feeling sensation, but now it starts to hurt, and it hurts and hurts and hurts. But I actually still need the same amount of pressure to actually cause damage to the skin in this situation. So again, this is changes in how our pain system is working. And it's really just saying, warning, but the warning's happening a way sooner. And this is to sort of get at, like, we need you to get moving again. And you're probably going to notice some pain as you do that, but that doesn't mean you're hurting yourself. Okay. And how are we going to start working into that? It just, your nervous system's more sensitized right now because you've been dealing with this for 2 months or 3 months or 6 months or whatever. Just a little plug for physical therapy. This was a study out of Utah. Again, sciatica, that again could be broken down into a number of different things. But for this group, at 1 year, a lot better outcomes for people who went through PT. So again, just getting at how can we get activated and moving again. And then, 2014. So remember, I'm lying on the floor in my bedroom. And I was doing this a lot because this felt really good. So this takes probably the most tension off the low back, is this position, or some people prefer the legs up the wall, which is another great position. But there's a bunch of things like this that can be helpful. Now, I was really lucky because being a doctor that does back pain, I felt pretty confident I didn't have something serious going on that needed like a surgery. So that was kind of the baseline level starting. I just really couldn't move very much. So I did this, and then I started getting into the AM yoga. So the AM yoga was just what I did. This was like a 12-minute video. It's just a very brief kind of back and hip opener series, a yoga thing. And that really helped me get through my guarding because I was able to slowly work into doing some motions with that. And then I took ibuprofen. If I can get up there. And that really helped with the pain. In about 3 to 4 days, I was back on my feet. Things were still kind of sore, but I was getting going. And then I was doing okay. And obviously, everybody has a different story about back pain and things like that. But that's what kind of I went through. So that's that. This was just a blank slide that I just didn't put anything on. So that's it. Yeah, we can do questions.
I don't know how many you have, Aaron, but I'll start out if you want to just go every other, if you've got some other ones. First, just a comment. Like what percentage of our day is taken up with people calling in about their scan that they saw first, right? It just happens so much, and it takes up so much of our time, or my nurses' times. But my first question would be tramadol. Gosh darn it, and in my job, I see a lot of people show up on tramadol, or people prescribing a lot of tramadol because they don't think it's a problem. What's your thought?
Yeah. So again, if we go back to where I sit on opioid prescribing, I'm pretty conservative. So for acute pain, and we're just trying to get through a few days, I don't have a problem with too much of anything, again, depending on the person. And tramadol, I think, is a relatively safe one as far as that goes. I try to always clarify with patients, because lots of times patients are under the belief that it's not an opioid, or, I don't need oxycodone or hydrocodone, I don't need an opioid, I'll just get some tramadol or something like that. And so I try to clarify that it is an opioid and sort of how it works. And then also it can have some interaction. So there's some concerns, especially if there's any concerns around seizure stuff, you got to be careful with it. And then it also has the sort of SNRI part with it. So serotonin syndrome. So usually another thing so it's just a little bit kind of, messy is maybe not the right word, but there's some complexities to using it. And so I just don't prescribe it. I got like 2 or 3 people. I inherited a couple people on it, and then another person that I had started on it back when I had first started practicing, and it's kind of worked. But so I don't recommend it. I don't use it very often. I think there's a ton more tools that are helpful for people. And again, in general, I really like to move towards, I'm the doctor managing your pain versus you, the patient, are managing your pain, and doing these things to try to help manage your pain, which is more self-care. And so that's just my approach. I think overall, compared to other opioids, tramadol is pretty safe. But I haven't seen that people get a ton of relief with it. One, it doesn't seem to work as well as some of the other ones. And I just don't use it very much. So I guess that's my 2 cents on it. But I do try to clarify the education around that it totally is an opioid. And I think people need to know that.
I have a question. Do you have any wise words for encouraging patients to attend more than one session of PT, and just, encourage them that it'll be helpful, and not just quit after going once because they didn't find it helpful?
Sure. Yeah. So I think there can be a lot done to prep the person in the clinic visit before they get to PT as to why it might be helpful and successful. And so that's I think part of it. If it flares things up because they're so guarded and they can't really participate, that really needs to get taken care of, or they have to understand that they can move without causing more damage. And sometimes it's that information about, like, you can do this without hurting yourself, and that sometimes can be helpful. Some people are just kind of looking for the quick fix. They want the injection or the medication to sort of just take the pain away. And there's certain times where those things can act as a bridge for helping people kind of get better in conjunction with kind of what they're doing to manage stuff. And so I try to place that stuff in that I'm happy, if you want to try medicine in conjunction with doing PT, or we can get you set up for an injection with PT. And that, can be a bridge to help you be able to do the exercises more. If you've already had someone go to PT and they had a bad experience with it, then I'm just asking a bunch of questions like, what happened? interaction with the therapist. That's not very frequent. The therapists in general are pretty great. But it was interaction with the therapist, or, I just hurt more afterwards. Okay, well, we got to talk about Goldilocks then, right? Did you do too much? Did you do too little? Like, where are we at? And then you can start coming up with kind of plan. And if, it's not working for them to go, because sometimes it's just logistics, like I can't travel there or whatever, then I'm trying to set them up with something that they can do at home. There's a ton of stuff on YouTube, and you can sort of get people activated that way. I think there's probably having somebody go to PT and work with a therapist is always going to be the first choice over, having them try to do some exercise at home. But you got to kind of meet people where they're at and sort of see how it goes. And sometimes it's like, yeah, you've been kind of doing your thing without doing the PT, and you've been really hurting. Are you at the point now where you want to give it a try or not? And sometimes that's where it is. But yeah, it can be really challenging.
Isaac, if you want to stop sharing your screen, then we'll.
Oh, sure.
People will pop out. A lot of people on this call, I'm sure, do some bupe for pain. Do you have a preference, patch versus pills? Or
did you say bupe?
Yeah, buprenorphine.
Yeah. So for my older patients, I really like the patch because it's a lot easier. Just logistically, they can put it on and you leave it on for a week, and that's it. And most people are trying to reduce the pill burden if they can as patients. So I use the patch a lot. A lot of it's like coverage. And so, if whatever's not covered, then it's not covered and it doesn't work. But I do like that. I've had some issues with people just like the Belbuca and the films, like it's gummy or it tastes bad or blah. So in general, I do use the patch. Sometimes that's not enough if someone's coming in on opioids already. And then usually I'm going to Subutex or Suboxone. But again, it's sort of like, a lot of this, again, is converting people already on opioids. And so it's not, pain management, if we get some of that, I'm excited about that. It's a lot about like safe. And also people notice how they were feeling on the opioids once they switched to bupe and how it's different and start able to engage a little bit more. That's been my experience. So yeah, I like the bupe. Sometimes, especially in the older crowd, the irritation from the adhesive from the patch is an issue. And so usually we use Flonase. I'm not sure if they've talked about that on here, but you can get the over-the-counter Flonase type stuff and squirt it on the skin, let it dry, and then put the patch on. And that tends to really reduce the skin irritation with the patch. So pro tip on the butrans there, I guess.
Yeah, I've never heard that. Do you have another one, Aaron?
What's that?
I was just seeing if Aaron had another question. Otherwise, I got more.
No, but Sarah Hall, back to the PT topic, had a really nice suggestion in the chat. And she says, just like if you are trying to tone your muscle, you can't lift a 3-pound weight once and expect changes. Even though it may have not been a good experience in your past, it is important for you to learn how to move better with your pain. And then she says she sends them to a PT that understands chronic pain and how to pace the activity.
Yeah, that's a great point. I didn't get into the pacing, but there's a lot of great literature. And again, this is the chronic pain group. And I get that our talk has just been like a huge, huge span of things. But that pacing reduces the amount of flares by about 50% and the intensity of flares by about 30%. So chronic pain flares just by pacing appropriately. And so it's something that I almost always talk to my patients about. Again, that Goldilocks thing.
Yeah. Do you, when I was doing family practice, I can't tell you how many people I inherited who were 85 and had spinal stenosis and had been on opioids for 20 years. Would you say that the majority of those patients, probably their pain was from something else and wasn't even the spinal stenosis in general? Yeah,
it's hard to know. But we see a ton of this on, I showed the data there where, the vast majority of people are asymptomatic from their spinal stenosis. And it can be sort of a over time thing. It may have been at the time the spinal stenosis was really bad, and then the inflammation around that calmed down, and then they were kind of fine for a while, but they just stayed on the opioids too. So again, as I just said a number of times, just having that stuff on the imaging doesn't mean it's causing pain. We really got to sort that out. And so, yeah, I think a lot of people got started on opioids for a lot of things that were probably self-limiting things, and then just stayed on them because that's how we did things for a long time.
Yeah.
So
do you typically kind of attempt to like taper those people, or just say, listen, you may not need this now. Let's try and bring it down?
yeah, I always talk to people about the option of either tapering or transitioning. I think one is that so it's a little bit tricky because I shouldn't say nobody, but lots of people don't want to manage opioids, right? And as we kind of went through stuff with the opioid epidemic and all the guidelines, people were just really like, I don't want to touch this. I don't want to touch this. I don't want to touch this. And it got to be a little bit challenging in that, a patient comes in their 80s, they're on 2 hydrocodone a day, and they want the pain specialist to manage that. And it's just sort of like, this really doesn't require, the expertise around that. And their person who's been prescribing for them and says, there's no way I'm going to do it. So it just ended up being this kind of tricky situation. And so when those patients came in, either I'd have a conversation with the primary and say, hey, look, this has been going on for 30 years. It's relatively safe. The patient doesn't want to get off of it. I think it's, something we can kind of manage. And those would be some of them. A lot of patients are just like, oh, I didn't know I could stop these. And you try coming off of them, or they haven't had other pain care. Like they just had a bunch of opioids. And it's just sort of like, they get regular pain care and then we can kind of get off of them. Or in these cases, I'll rotate them to Bup 2, even if it's sort of low dose opioids, just because the ease of being on something that they can use once a week versus having to take pills every day, they appreciate. So it depends a little bit on the person, but those are usually how I kind of approach that.
Do you have any tips for getting the buprenorphine patch or Belbuca covered?
Yeah, it's really insurance dependent, and that's a really difficult thing. So I know I've been talking about it a fair amount, but lots of times it's not covered, and then you're just kind of stuck with that. I believe there are some online coupons that sometimes people can use as well to help reduce the cost of it, but almost always it's going to be more than their 60 tabs of oxycodone they were getting beforehand or something like that. And that's always a difficult thing to navigate. But yeah, I know at least at Health Partners, we've had both that and Belbuca put on the formulary, which has been made it a little bit easier to do. So people are starting to get the word on it. And usually I'll write something to the insurance company when they want you to like try methadone first before the Butrans patch. I'll just be like, hey, there's a, I don't remember the exact thing, but there's basically like looking at geriatric pain. There was some recommendations where buprenorphine was really the first line choice due to all the potential side effects with the other ones. So usually I'll cite that and put in something, and sometimes we get it and sometimes we don't. But yeah, it's a really difficult thing. I totally agree. Because
I was just trying to do one, and they went through the alternate meds. It was like disulfiram and naltrexone. I'm like, no, I'm not. That's not what I'm treating.
Yeah. It's been really, yeah. One
trick you can do is use the 2 milligram films, and you can cut those up pretty small.
Yeah, do that a lot. I've had some difficulties, especially my older patients with arthritis. It's a little bit harder for them to actually do that. So that's just another factor. But I've done that a number of times. It's just gotten the films and had them cut those up. And I think as I've used it more, I've gotten a little bit more liberal with the dosing. I think the safety profile is really good. And so if I was going to do something with Belbuca, I don't feel too bad or too concerned if I'm now up into the films where you have a little bit higher dosing, but they can actually get it covered. Because I still think that's way better than being on, fentanyl or methadone or oxycodone or something like that from a safety standpoint.
Yeah, what Kurt said, you can give 32 milligrams and nothing bad happens.
Yeah, I mean, it seems like there's a really big window of safety with that. And that's one of the real nice things about the Bup. And I know at the hospital, we've gotten a lot more aggressive with starting people on it. And even like the concerns about precipitated withdrawal, we're sort of getting a little bit away from that as well. So things have really evolved with that medication over the last several years.
I can really appreciate Penny's comment in the chat, and she asks, do you approach redheads differently with pain management?
I don't. The principles still hold the same now. I think, and Penny, you'll have to maybe help me because I just have some cursory knowledge, but this gets a little bit at like medication metabolism. Is that it? Or higher pain thresholds?
Penny, can you unmute, or do you just have chat?
So for me, when I take opioids, I have really bad mental health symptoms associated with it. I'm really angry and depressed, and it takes a long time for me to come out of it. So I cannot take them. It just messes up my mental health. And then I've had a couple of surgeries where I don't stay under as long. I metabolize the anesthesia too fast.
Yeah. Oh, yeah, that sounds hard. So yeah, I don't, not specific to redheads, but just specific to the person. So if you were saying you were having those symptoms, we would sure try something different to try to help you feel better. But I guess I haven't really seen, again, I don't use a lot of the opioid medications. So I don't know that I've seen a lot specific to people that are redheaded, but I know there is some concerns out there about that. And there's probably something genetic that I thought there was some stuff about that they've looked into that. I don't know. Someone will have to help me out.
Yeah.
Yeah. Thanks for the comment.
Yeah. One quick thought before we go, it's interesting because I had done some research on benzos with opioids, of course, and with buprenorphine. And actually we have some patients in our program for addiction programs that are on some benzos, and they're on buprenorphine. And in fact, your risk of overdose is higher if you're on a benzo alone than if you're on a benzo with buprenorphine.
Oh, interesting. What's the mechanism for that?
Well, it's just that they, if they're not on buprenorphine and they're only on a benzo and they use opioids.
Oh, sure.
And in fact, the retention rate of patients who are on a benzodiazepine in a buprenorphine program is actually higher.
Oh, interesting.
Yeah, which is, to me, and we've always really avoided it, but then on the other flip side of that, when you get these older patients come in and they're on opioids and somebody puts them on a benzo and puts them in the hospital, which I had recently, she stopped breathing with just 1 or 2 Ativan. Then bup is a really good choice, right? I mean, it's safety. And so I switch quite a few people over, much like you do, that get sent to us with these issues. So yeah, it's fun stuff. Any other questions before we let Isaac go? Boy, great talk. Fabulous. All right. Well, as usual, another great talk, Isaac. I really, really appreciate you.
Yeah. Thanks for having me back. I really appreciate it, and just really love all the stuff the Echo does. So I'll see everybody. I think in a few weeks I'm back again, if you can believe it. So.
Oh, I didn't even know that. I didn't see that one on there.
Yeah.
All right. Well, thanks again. And thanks everybody for coming. We'll see you guys next week.
All right. Thanks.
All right. Bye-bye.